Yes, sir.
10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Here we go. So, good evening, ladies and gentlemen. I'm really honored and privileged to have you all today in this grand rounds. This is the third in the series, and Professor Anthony has been kind enough to do all our grand rounds, and we'll have one again tomorrow. Today, we are going to discuss a case of hypopharyngeal growth, and it's going to be discussed by a third-year exam-going PG, Dr. Lakshmi. So I may not be able to actively participate in this because I have to go for an emergency. Of course, Professor Anthony will take over. Thank you, Professor Anthony, for always being there for students and sharing your academics with the whole world. This grand rounds is a super duper hit. The whole whole globe is watching you, and the grand rounds is the most wanted, program now on the YouTube. Thank you very much, Professor Anthony, and over to you.
Thank you, Janagram. Thank you. But for you, this would not have been possible. We have been doing this for a long time. So every year I used to think I'll take a break, but seeing your enthusiasm and the way you conduct like a opera, I am pulling along. Okay. Fantastic, Janagram. Thank you very much. Thanks for all the concern in you. I told you already, you are a congenital chronic teacher. So thank you very much for everything, for arranging everything. And that banner of Royal Pearl and Janagram carries it to the nook and corner of the world. That is for sure, right?
That is because of Professor Anthony. Yeah. So over to you, and I think over to Lakshmi, madam.
Yeah, Lakshmi. So Lakshmi is our All India postgraduate. So she's supposed to be a very brilliant girl, and how brilliant she is, we'll examine today.
Before that, can I make an announcement, Professor Anthony?
Please, please, please.
Okay, we have 2 vacancies at Royal Pearl Hospital for a fellowship, 1-year fellowship. In case any of you postgraduates want to apply now, because the seats are going to be filled very soon. I've told Professor Anthony also to recommend some very brilliant PGs to us. It's for 1 year, and it'll be super intense ENT training. Thank you very much. Over to you, Professor Lakshmi. Dr. Lakshmi.
Good evening, sir. So can I start screen sharing, sir?
Yeah, of course. Yeah.
Hello, sir.
Yeah, you can see. But you are starting from provisional diagnosis.
Sorry, sir. Shall I start, sir?
Yeah, please.
So presenting a case of 52-year-old male coming from Kanchipuram with complaints of difficulty in swallowing for 4 months and change in voice for 1 month.
Okay. So what is dysphagia?
So dysphagia is defective in transportation of food, micronutrients, and endogenous substances from oral cavity to stomach.
So dysphagia is the defect in the transportation of micronutrients, endogenous secretions, and electrolytes from the oral cavity to the stomach. Okay, it may be because of mechanical obstruction, it may be because of defect in the neural component, or maybe because of some other severe infection, inflammation, and things like that. But whatever it is, that's a cause for dysphagia. How do you classify causes for dysphagia?
Dysphagia can be classified into oral, pharyngeal, and esophageal causes, sir.
Esophageal causes?
Again, it can be divided into infective, inflammatory, neurogenic, iatrogenic, and traumatic cases, sir. And congenital causes.
You mean to say oropharynx or oral cavity or esophagus? I asked esophagus. How do you classify causes for dysphagia of esophagus?
Intraluminal obstruction and extraluminal obstruction, sir.
Intraluminal on the wall and external. All the wall. Okay, right. So proceed. So what is pain during swallowing is called?
Odinophagius, sir.
Continue.
The patient presented with difficulty in swallowing for 4 months, which was insidious in onset, progressive in nature, and initially it was for solids, and later it progressed for liquids for the past 1 month, and not associated with the history of nasal regurgitation or pain during swallowing, and no aggravating or relieving factors. And history of ear pain was associated for that for the past 3 months.
Why there's an ear pain?
Because it's due to referred otalgia, sir. Because the same nerve supply for the external ear and piriform fossa.
What is the nerve which supplies the
Hypopharynx.
piriform fossa?
Arnold's nerve or Alderman's nerve, sir.
It supplies the ear.
Ear. It's recurrent laryngeal nerve, sir. Gallant's anastomosis is there between internal laryngeal nerve and
I'm asking you plain and simple question. What is the nerve supply of the sensory supply of the piriform sides?
Internal laryngeal nerve and recurrent
internal laryngeal branch of the superior laryngeal nerve. So this you are telling all the answers. How it is referred to the ear? Because
both are perceived at the same sensory level, sir. This inferior cervical ganglion.
What is the nerve which supplies the ear?
Alderman's or Arnold's nerve, sir.
Why it is called Alderman's nerve?
Because they used to stimulate the appetite by putting alcohol into the ear.
So alderman or the group of clergy, they go to every house and everywhere they used to give them some food, and they used to take the food and bless them. So to increase their appetite, they used to pour alcohol in the ear, which is supplied, which stimulates the vagus, which increases the gastric motility. That's why it's called Alderman's nerve. Alderman's nerve. Okay. Then when the patient is complaining of dysphagia, and particularly of this magnitude, will you say it's associated with anything else? How do you classify dysphagia?
Oral, pharyngeal, and esophageal causes.
Classify dysphagia.
Any neural causes to be
no. Classify means how will you grade dysphagia?
Madanagopal's grade system is there, sir. So grade 1 is
who is Madanagopal?
There is a professor in our Madras Medical College. So, sir,
he is a gastroenterologist in Madras Medical College, who's the one who's pioneer in opening up the department. They have a separate hospital in Ananagar. So he is the one who has formulated the grading which he follow in Madras Medical College. What is that?
So grade 1 for solids like chapati, and grade 2 for semi-solids like rice, and grade 3 for kanji or
semi-solids.
Semi-solids. Then grade 4 for liquids, and grade 5 for endogenous secretions like saliva, and grade 6 absolute dysphagia, even to saliva.
Okay. So that is the grading. Okay. And then if the patient is not able to take food for 4 months, this patient can swallow only saliva or not even saliva. What will happen to the patient?
Patient will be acute malnutrition will be there.
There will be a severe loss of weight. So you should always tell whether it's associated with loss of weight or not. If there's with 3 months dysphagia, patient has got a severe loss of weight. That means the dysphagia is very significant and is having effect. So you can't say, as I told you, believing patient symptoms is, depends upon person to person. Few people tend to exaggerate. So you always ask for history of loss of weight along with the dysphagia. If there's a dysphagia with loss of weight, you always think that it is a significant dysphagia. Okay. Then next.
1 minute, sir.
See, usually we grade dysphagia because the people normally everybody won't. When you are ready, you tell me, right?
Yes, sir.
Yes. Fine. You proceed.
The patient also had history of voice change for 1 month, which was insidious in onset, progressive in nature, worse in character, non-remitting, and no associated diurnal variation, and no specific aggravating or relieving factors. History of foreign body sensation was associated with that, and history of loss of weight and loss of appetite was there.
Previous slide. In the last class, we told about what are the danger signals in dysphonia. What are the danger signals in dysphagia? Dysphagia itself is a very dangerous sign. Signal. So, what are all the associated danger signals in the dysphagia?
Absolute dysphagia or a dysphagia
fastly progressive dysphagia. Then
and dysphagia associated with weight loss. Then
weight loss. Dysphagia proceeds to form or proceeds to associate with hoarseness. Dysphagia with a neck swelling. Dysphagia with loss of weight, loss of appetite. All these things are all danger signs. So every time you see a dysphagia and with other associated these things, you got to be very careful. Then.
Sir, shall I move to next slide, sir?
Yes.
There is no history of neck swelling, no history of breathing difficulty.
Why do you look for neck swelling?
Any secondary metastasis can be there,
okay.
Or direct extension of malignancy can be there, or any other.
Where is the direct extension of malignancy?
In hypopharynx, it can be from the pyriform fossa through the thyroid membrane, and if it extends from the pyriform apex to the extrathyroidal tissue.
How does the growth spreads in the hypopharynx?
From the pyriform fossa, it can spread laterally through the thyroid membrane to the neck, and also it can spread medially into the paraglottic space. Then so superiorly it can go to the pharyngoepiglottic fold and oropharynx. Medially it can go to post-cricoid region. Cricoarytenoid joint can be involved. Then through the cricothyroid triangle, it can come out as extra thyroidal extension. Then it can also, if thyroid cartilage is involved, it can cause thyroid gland involvement also.
See, this doesn't have a spaces like that of the larynx. So the proper spread cannot be measured like how it is in the larynx. If it starts in the rinky space, it comes to an anterior commission, stops there, then goes to the opposite cord, then it goes above and below, become the that will not be seen in the pyriform fossa growth. But the danger with the pyriform fossa growth is anteromedially pyriform fossa is related to the paraglottic space. The involvement of paraglottic space makes it difficult for it to do a partial surgeries. So any growth which is on the medial wall of pyriform sinus, that partial laryngeal, partial pharyngeal surgery is ruled out. Okay. Similarly, when the patient involves the deep part of the pyriform sinus, the deep part of the pyriform sinus, what are all the boundaries of pyriform sinus?
Pyriform fossa can be divided into two, sir: membranous and cartilaginous part. The membranous is the superior portion, and it's bounded laterally by the thyroid membrane on the upper part and thyroid cartilage on the lower part. And medially, it's aryepiglottic fold on the superior part and arytenoid cartilage on the lower part, and superiorly pharyngoepiglottic fold. And it forms the apex, and cartilaginous portion is formed by cricoid cartilage on the medial.
It continues down as the apex or the deep part of cartilage part of pyriform fossa. Okay. Then deep part is bounded.
Deep part is bounded by cricoid cartilage on the medial side and thyroid cartilage on the lateral side.
Thyroid cartilage, cricoid cartilage, and the cricoid joint, lower part of the cricoid joint and the cricoid cartilage. So when the growth is medially, you can't do the partial laryngectomy. If there is a compromised laryngeal function, you can't do a partial line. So always you need to remove larynx totally or near totally. If there is a one cricoid joint is free, then we can do a near total laryngectomy. But if there are cricoid cartilage is involved,
no conservation surgery.
No conservation surgery. So because it is so close to the cricoid cartilage and the apex of the piriform fossa is involved, it's oncologically it is not possible to leave behind a part of a larynx. So you can't even do a near total laryngectomy, leave alone partial laryngectomy. So this is the drawback of the piriform fossa. Similarly, it can easily become a circumferential tumor. The circumferential tumor means it can go to the posterior pharyngeal wall, post-cricoid area. Then it becomes a bilateral tumor. When it becomes a bilateral tumor, your aim should be thinking about the taking the whole pharynx. And the second important thing is it is very, very rich in blood supply. I mean, and sorry, it's very, very rich in lymphatics. Okay, so you got to always look for neck swelling for the secondaries. So what is the percentage of secondaries in piriform fossa growth?
70%.
So what is the percentage in the contralateral neck?
20%.
5%. 5% of the tumor can have the contralateral node. Okay, so when you have this piriform fossa, opposite piriform fossa also can contain node, and there is nothing called N0 neck. 40 to 50% of the patient will have a secondary deposit in the neck in the occult disease. So always when you address piriform fossa, you palpate both sides clearly. You do your radiological investigations, even if it is N0 neck. When you are planning for a treatment, you got to give. Even if you do a surgery, you got to do a bilateral neck radiation. Okay. Then why difficulty in breathing?
Because it can involve larynx. Direct invasion can be there. It can be in the thyroarytenoid involvement in the paraglottic space, or direct cricoarytenoid joint involvement, or can be after the extension to the post-cricoid region and cricoarytenoid joint involvement, or bulk of the tumor, but it's less chances in the piriform fossa. And recurrent laryngeal nerve also can be involved.
Okay. So and there can be a direct extension if the tumor is deep involved in the below the cricoid, can go inside the directly inside the upper trachea and the subglottic area. So all these things can produce difficulty in breathing and stridor. Okay. Why cough? Restriction of neck movements.
The cough for any aspiration can present as cough.
Why aspiration?
Because if hemilarynx is fixed, there can be chances.
When there's an hemilarynx is fixed and there is absolute dysphagia, it will regurgitate back. Like nasal regurgitation, it can come back, it can go inside the trachea. That's called spillover. This is called the obstruction spillover. So the patient can aspirate aspirate the fluid, can bring out like a cough. Why restriction of movements? Neck movements.
If prevertebral fascia is involved, there will be restriction of neck movements, mainly for looking upward, sideward, or lateral.
Okay.
So,
and also, patient cannot look up. Patient will have pain when the patient is looking up. Okay. Right. Ear block, ear sensation, all for all other cases. Right. Next slide.
The past history is not a known case of diabetic, hypertensive, CAD, pulmonary tuberculosis, asthma. No history of any surgeries in the past or any previous hospitalization. No history of blood transfusion or drug allergy.
When Sriharsha was presenting, he told a mnemonic. When we used to tell past history, it was patient not known hypertensive, diabetic, anemic. Anemia is important, particularly in the post-cricoid growths. And then contact tuberculosis, contact with STD, with STD or contact with STD. So anemia is another important thing you have left out. Then what is the patient's name?
Rajan, sir.
Okay. If there is a post-cricoid growth, you should also ask for a personal history, a menstrual history, because menorrhagia can cause chronic anemia, and chronic anemia may lead on to the Plummer-Vinson syndrome, and Plummer-Vinson syndrome can cause malignant transformations, the pre-malignant lesion. Okay.
Okay, sir. Coming to personal history, he takes mixed diet, sleep is normal, appetite is decreased, and bowel and bladder habits are regular. He's a chronic smoker for 30 years. He used to smoke 1 pack of cigarette per day for the past 30 years and stopped 4 months back only. And he's occasionally alcoholic.
Does he give any history of HPV infection anywhere else?
No, sir.
Can this HPV infection cause malignancy?
Papilloma can be there in the larynx, sir. Can be a risk factor.
Supraglottic growth and the hypopharyngeal growth. Fungating tumors are more associated with the HPV infections.
Okay.
There is no direct correlation, but overexpression of P53 and the HPV are the causes for the exophytic growth, which gives you the reasonably better results compared to that of the other cancers. Other clinical type of the hypopharyngeal cancers. Okay, then with this you are finishing your history, right?
Yes, sir.
You have any other slides for history?
No, sir.
Now tell me where do you think there is a problem?
The patient had progressive dysphagia for 4 months or a short duration of time, and he also had a history of voice change. So probably the site of origin would be a post-cricoid region or a piriform fossa apex region. Sir.
It's an hypopharyngeal tumor.
Hypopharyngeal tumor.
First possible subset, what do you think is post-cricoid?
Post-cricoid. Or
second possible subset is piriform sinus. But what is the other subset?
The larynx can be there, but
what is the other subset in the hypopharynx?
Posterior pharyngeal.
What is the boundary of the posterior pharyngeal wall?
Superiorly the hyoid bone, inferiorly the lower border of cricoid.
The level of hyoid bone, inferior the lower border of the cricoid. What is the lateral extension?
When the vocal cord is in cadaveric position, an imaginary line is drawn to the posterior pharyngeal wall, and it also corresponds to the space between the two piriform apex.
Space between the two piriform apex. Okay. Then what is the boundary of post-cricoid area?
It's a strip of mucosa lying behind the below the arytenoid and to the lower border of cricoid region.
So it's a strip of a mucosa situated anteriorly from the arytenoid cartilage to the lower border of the cricoid cartilage, which is continuous laterally to the apex of the piriform sinus, and inferiorly it extends up to the introids of the esophagus. Okay, so this is the boundaries. Okay, when we were studying, we used to have two piriform sinus. Then you have a siphon-like circular area, which is called the post-cricoid. But now that circular area is gone because you can't differentiate lateral wall from the apex of the piriform fossa or the posterior wall from the posterior pharyngeal wall. So now the post-cricoid region is only a strip of mucosa, which is just behind the cricoid cartilage. But the problem is already this is very enough to give more problem for us in making diagnosis. Okay, then proceed.
On general examination, the patient was moderately built and poorly nourished. and no pallor, no icterus, cyanosis, clubbing, or pedal edema, or generalized
Why?
lymphadenopathy.
Tell me few reasons why you call it as a post-operative tumor.
The patient presented with dysphagia, sir, and
Okay.
also patient had a history of voice change also
Okay.
for past 1 month. So it can be the direct infiltration of the tumor to
Tell
the
me
psychosis.
few reasons to tell that it is not a it may not be the post-operative area.
One is the gender, sir. Most
Okay.
commonly present in the
So
females.
only malignancy which is common in females are
Post-cricoid.
post-cricoid tumor. I have operated about 4 total laryngectomy with the esophageectomy in the past 5 years. All the 5 are females. Okay. I have operated the male when I was an assistant professor here, not after I become professor. Okay. Then what is the other reason to say it is not?
There is no pallor, sir. Mostly post-cricoid tumors are associated with cytopenic anemia.
Anemia. Okay. So these two are the contradicting points. Which tumor will produce voice change early? Post-cricoid or posterior pharyngeal?
Post-cricoid, sir, because direct invasion into cricoarytenoid joint can.
Which tumor is common?
Pyriform fossa tumors are more common. After that,
tumor occur. Second is the post-cricoid. How the pyriform fossa growth causes focal cut paralysis?
It can have direct invasion to paraglottic space.
Paraglottic space. So which is more common?
Muscle will be involved, sir.
Which is more common? Paraglottic space involvement is more common compared with that, the direct invasion of the cricoarytenoid joint. How many direct invasion of cricoarytenoid joints you have seen? Most of these voice changes are all usually due to the thyroid, due to the thyroid muscle infiltration. Okay, right.
Then vitals, BP is 130/90 on millimeters of mercury on sitting position. Then respiratory rate is 16 per minute, pulse rate is 84 per minute, and SpO2 is 97% in room air. Coming to ENT examination, sir. Coming to oral cavity, lips, upper lip, lower lip, gum, buccal mucosa, hard palate, anterior two-third of tongue, floor of mouth all are normal.
What are the pre-malignant conditions of oropharynx? Oral cavity.
So it can be divided into highly malignant, high risk, moderate risk, and low risk pre-malignant condition. High contains spectral leukoplakia and erythroplakia, then chronic hyperplastic candidiasis, then moderate contains leukoplakia, lichen planus, and oral submucosal fibrosis, and low grade.
Which type of lichen planus? Which type of lichen planus? Serpentine lichen planus. Okay. Then what is a low risk pre-malignant conditions?
Aphthous ulcers, candidiasis,
bald tongue, atrophic mucosa, atrophic mucosa, chronic gingivitis, chronic inflammation, and then angular stomatitis, cheilitis. All these things are all low risk. What are all the risk factors for oral cavity malignancies?
sharp tooth, spices, syphilis, then spirit,
smoking, then
syphilis,
susceptibility. genetic susceptibility. All these things, all 7 S's are the pre-malignant, causes for the oral or oropharyngeal malignancies. Okay. Then indirect laryngoscopic finding.
Base of posterior 1/3 of tongue, median glossoepiglottic fold, bilateral glossoepiglottic fold, then vallecula, epiglottis were normal. Then right pharyngoepiglottic fold, pyriform fossa on right side, and true vocal cord on right side, and false cord were normal on right side. Posterior pharyngeal wall was normal, and on a slough covered proliferative lesion with everted margins were present over the medial wall of pyriform sinus, left pyriform
Don't call
sinus.
lesion. You don't call lesion. It's a growth.
Okay.
Proliferative growth with everted margin present over the
medial wall of left pyriform sinus, extending anteriorly from the pharyngoepiglottic fold and medially to the aryepiglottic fold, and posterior and inferior extent couldn't be made out, and lateral wall was free, and left false cord, a bulge was present, and left aryepiglottic fold and pharyngoepiglottic fold were thickened, and left hemilarynx was fixed. Glottic chink was adequate, and there is minimal pooling of saliva. Ulceroproliferative lesion with everted margins present over the medial aspect of left pyriform sinus, with extending anteriorly to the pharyngoepiglottic fold and medially to the aryepiglottic fold, and posterior extent and inferior extent couldn't be made out, and left false cord.
Okay, then.
Okay. Then left false cord shows a bulge over there, and left A fold was thickened, and also left pharyngoepiglottic fold was also mildly edematous compared to the right side.
Okay.
On examination of neck, the laryngeal contour was normal, laryngeal crepitus was present, trachea was in midline, no stridor, and
what are all the neck features of post-cacad area? Post-cacad growth.
The laryngeal crepitus will be absent in
absent. Okay.
Then if the tumor is in advanced state, it can have a thyroid involvement, and extra thyroid tumor.
Post-cacad growth comes to the thyroid cartilage, is it? How it will come? Post-cacad, first it should come to the pyriform fossa. From the pyriform fossa, it will become big and it should involve the lateral wall. Then erode the thyroid. Then it will come rare, very rare. Post-cacad growth will not produce thyroid involvement. Rather, it will produce the posterior pharyngeal wall involvement because it will become a circumferential growth. Okay. It will push the cricoid cartilage to the front. So this will cause widening of the laryngeal framework. Laryngeal framework will get widened. There will be an absence of laryngeal crepitus. What are the the absence of laryngeal crepitus is called what?
Boca sign positive.
If the Boca sign is positive, what does that mean?
That means there is disease is there, and there is something obstructing between the cricoid lamina and prevertebral.
So what are the components of laryngeal crepitus?
Cricovertebral component is there, and thyrovertebral component is there, sir.
It's a thyrovertebral click and the cricovertebral click. What is cricovertebral click is due to?
Can be due to post-cricoid growth, or it can be also due to
No. Why there is a grating sensation when you move the cricoid cartilage? Why there is cricovertebral click?
The larynx, the posterior part of the cricoid moves freely over the prevertebral regions, prevertebral pressure, which is over the vertebral.
There are two bones which grates, or two hard surface only can grate. What are the two hard surfaces?
Cricoid and the vertebral.
Posterior lamina of the cricoid cartilage with the
vertebra.
Vertebra is huge.
Body of the vertebra. Body of vertebra.
Body. What is thyrovertebral?
It's a grating sensation with the lateral border of thyroid cartilage to the
posterior border of the thyroid cartilage.
Posterior border of the
lateral lamina of the thyroid cartilage with the
which the transverse process of vertebra.
Transverse process of the vertebra. Okay, so the thyrovertebral click has got two components. I mean, laryngeal cryptus has got two components: thyrovertebral click and the cricovertebral click. Cricoid posterior lamina of the cricoid cartilage grating upon the posterior pharyngeal wall is called the thyrovertebral click. Posterior border of the lateral lamina of the cricoid cartilage grating over the transverse process is the thyrovertebral click. Okay, right. When will you get the absence of thyrovertebral click?
Unilateral
When you get the absence of laryngeal cryptus?
Thyrovertebral click can be absent. In unilateral.
We'll come to the pyriform sinus later. Post-cricoid area.
Post-cricoid tumors can cause absence of cricovertebral click, and also retropharyngeal abscess can also cause.
Retropharyngeal abscess, post-cricoid, all these things can produce loss of cricovertebral click. What are all the features of pyriform? And then when you do an indirect laryngoscopy examination, you will not see the mass. Okay. All you see is the proptosis of the arytenoids. Arytenoids will look forward and area epiglottic fold appears shorter. Then you see the pooling of saliva. Okay. In the case of a post-cricoid tumor, that pooling of saliva is called
Jackson sign.
Jackson sign. So these are all the clinical features of the post-cricoid tumor. That is, when you do an indirect laryngoscopic examination, you get a bilateral pooling of saliva, proptosis of the arytenoid, larynx appears compressed anteroposteriorly. When you examine the neck, there will be a widening of the laryngeal contour, and there will be a laryngeal cryptus absent. The patient can have a neck nodes. Okay, these are all the features of post-cricoid tumor. If the tumor becomes bigger, you see the tumor jetting out of the lumen behind the arytenoids. Then how it spreads?
Post-cricoid tumor.
Post-cricoid tumor.
It can directly involve the cricoarytenoid joint. Then it can directly involve.
Listen. Infiltrative is late. Infiltrative is late. Spread means it spreads on the surface. Okay.
Inferior.
From the post-cricoid, it can go laterally or inferiorly. So laterally, it can go to
pyriform fossa.
Pyriform fossa. So both sides can go to the pyriform fossa.
Inferiorly,
then it can involve the cricoid joint, causes vocal cord fixation. Or it can go inferiorly. What is peculiarity about post-cricoid growth?
The submucosal extension will be.
It can extend how far?
10 centimeter, up to 10 centimeter. It can
up to 10 centimeter. So you can have a skip lesions. You can have a ulcer one place. Within 10 centimeter, you can have another tumor. I mean another area. In between, you have a submucosal spread. That is about the post-cricoid tumor. Laterally, it goes. It involves the pyriform sinus. Once it involves the pyriform sinus, the more to one side, you get the nodal status early. Okay, so if pyriform post-cricoid growth per se will produce less amount of nodal metastasis, but if it spreads to the pyriform sinus, the chances for metastasis is high, because only 40% of the post-cricoid tumors will have a secondaries, while 70% of the pyriform fossa tumors will have a secondary sting. Okay, then how does the pyriform, what are the clinical features of the pyriform sinus?
Early patient will have referred pain, referred otology will be there. And in late cases, if extend, the patient will have dysphagia when pyriform apex is involved. Then if direct invasion to the larynx, if it spreads to the paraglottic space, patient can have hoarseness of voice and and sometimes if tumor is so big to involve the marginal zone of laryngeal inlet, marginal zone, that is A4, then patient will have throat pain and foreign body sensation. So.
See, tumor spreads above, below, medial, lateral. Laterally, it comes to the lateral wall of pyriform sinus. Lateral wall of the pyriform sinus is exposed to the neck, where it can involve the thyroid through the thyroid membrane. It can come out, or it can involve the perichondrium of the thyroid lamina. Which thyroid lamina is amenable for invasion? Ossified or
Ossified is more prone for invasion, sir. Because
so ossified. What is window ossification?
The ossification starts in the inferior corner and it progresses to the midline, sir. And also in
the margins of the thyroid cartilage gets ossified early. The center part of the lamina is ossified late. That's why it's like a window. It ossifies. It's called a window ossification. Okay, so the ossified thyroid cartilage is more amenable for invasion than the cartilaginous thyroid part, thyroid lamina. Okay, somebody asked about the spread of the post-cricoid again. So post-cricoid spreads from the post-cricoid area. You will not see any tumor. Because post-cricoid is an hidden area, you are doing even doing the indirect laryngoscopic examination. It's only two-dimensional view of the post-cricoid area you will see. So once the tumor becomes bigger and bigger, it pushes the thyroid lamina anteriorly. It makes the arytenoids to become more prominent. That's called an proptosis of the arytenoid. Then the larynx will be compressed anteroposteriorly. There will be a pooling of saliva. Then once it becomes bigger, it becomes a circumferential tumor. Once it becomes a circumferential tumor, it spreads by skip lesions. There will be a submucosal spread downwards, even to a 10 centimeter. So you have an ulcer at one place, 10 centimeter away, you have another ulcer. In between, you will have a normal mucosa, but submucosally there will be a spread. That's a problem with an inferior spread. Similarly, it comes laterally. The tumor is not known, not very common regional metastasizing tumor, but once it goes to the pyriform fossa, which is the common area for regional metastasis, once it goes to that area, it can cause accelerated lymph node metastasis. Then the tumor can fix the cricoidnoid joint. The commonest the problem with the tumor is the cricoidnoid joint fixation within hemilarynx fixation. Sometimes it can infiltrate into the paraglottic space and can produce the vocal cord fixation as a pyriform fossa growth also. Okay, so these are all the various presentations of the post-cricoid tumor. I think we have come to the stage of diagnosis, right? Okay, what's your diagnosis? Yeah, you had a lymph node. Sorry, I didn't see.
Swelling of size 2 cross 1.5 centimeter or the left level 2.
When you say 1.5 to 1.5 at the level 2 is insignificant too.
Okay.
We say 2 centimeters, it is significant. What do you want to tell? What do you want to tell? Don't tell me I have measured it. Nobody measures 2.5 and 2 and 1.5, right?
Just significant.
Okay, you want to tell it significant, right? Fine. Present.
Mobile, non-tender, firm to hard in consistency, no fixity to skin, and it was less prominent on sternocleidomastoid contraction. So no dilated veins or scars or ulcers over the skin.
Where does the the tumor spreads?
Sir?
Pyriform fossa tumor, where it spreads? Lymph node base.
Pyriform fossa spreads to tumors spread to jugulo-digastric and jugulo-omohyoid lymph nodes, sir.
Jugulo-digastric, mid-jugular. Mid-jugular, and also it can spread as a skip to the level 5 nodes.
Okay.
When it will involve the other areas, other nodes. If the apex of the pyriform fossa is involved,
apex and post-cricoid will drain to paratracheal nodes, sir.
Paratracheal, pretracheal, midline nodes, level 6 nodes, and also it can go to the supraclavicular and the jugulo-digastric nodes. Okay, so when the deeper and deeper at the apex of the pyriform fossa and the post-cricoid area, the spread will be at the lower part. That's on the jugulo-omohyoid, supraclavicular, and the level 6 nodes. Level 5, 2, 3 will be the upper part. where there is a superficial part of the pyriform sinus, that is called membranous part of the pyriform sinus is involved. Okay, this is about the lymphatic spread of the hypopharyngeal tumors. But we give a very stepmotherly treatment for posterior pharyngeal wall tumor. How will you differentiate clinically a posterior pharyngeal wall tumor from the post-cricoid tumor?
By dust test, sir.
What is?
Dust. After placing a tongue depressor, if we can see the growth, it's most probably arising from the posterior pharyngeal wall, sir.
Oh, then what test is that called? You say
Best. VEST.
best test. Okay. See, this is the this teaching is older, where they say anything below the level of the arachnoids is post-cricoid. Okay, so when you see the tumor, it is a posterior pharyngeal wall. But when you do a indirect laryngoscopy examination, then you see the tumor, then it's a post-cricoid tumor. But now the post-cricoid area itself is only the anterior wall.
Yes, sir.
So there's no question of posterior wall. So how will you differentiate it? Clinically differentiate with your clinical examination is very difficult. To see a tumor which is going down, you got to check it up whether it's a post-cricoid or a posterior pharyngeal wall by your imaging, or you do a endolaryngeal examination. Okay, right. So what's your diagnosis?
Ear and nose.
Yeah, no, fine. Okay.
It's malignant growth, hypopharynx, subset left pyriform sinus, T3N1MX, and stage 3, sir.
Why it's stage 3?
N1, sir, because T3N1.
You don't think the patient has got a show the video again? What do you see now? Wait. What do you see now? Wait, stop the video. What do you see now? Opposite side pyriform fossa opens and closes. What do you see now?
Opposite side is free, sir.
You see now what do you see? What is this? Yeah, what is that?
Pooling.
What is here? This side pharyngoepiglottic fold.
This side is
Lateral pharyngo. This side, what is that?
there is some amount of thickening.
No, below between that play and see that area. Is it not saliva? Even on the apex of the pyriform sinus, you see mild saliva.
Okay.
That means what?
Post-cricoid region.
Can you see that lower extension?
No, sir.
You see that pulling on both sides. Can you see when you now you see the membranous pyriform fossa on the left side? You see that's a bubble of saliva.
Okay, sir.
So what does that mean? You get pooling of saliva on both sides. What does that mean?
There is a post-cricoid spread will be there, sir.
Post-cricoid extensions
Extension.
got to be there, right? Because you don't see. Most probably there'll be a post-cricoid extension. How will you confirm?
By investigation, sir.
What investigation?
Hypopharyngoscopy can be done, sir. Or
Hypopharyngoscopy. Okay, then
or barium swallow can be done.
Barium swallow.
Or
okay. So what's your, if it is involved, what's your diagnosis?
Stage 3.
What's your diagnosis?
Malignant growth, hypopharynx, subset left pyriform fossa, stage T3.
Hey, it's extending to the post-cricoid area. Pyriform fossa growth extending to the post-cricoid area and possibly the larynx paraglottic area, producing. What's your focal cut status?
Fixed, sir.
Focal cut is fixed. Everything should come in your diagnosis. No.
Yes,
The
sir.
left pyriform fossa growth extending to the coryphoscaicate area, most probably postcoicate area, with the extending into the larynx, paraglottic area with hemilaryngeal fixation.
Yes, sir.
Most probably laryngeal part presents like a transglottic growth, because you see the bulge on the aviepiglottic fold. False vocal cord, you don't see the tumor at all, but it's got fixed the vocal cord.
Yes.
That's a transglottic growth.
Yes, sir.
Okay, when we have discussed the transglottic growth, we told it can also come from pyriform sinus.
Okay, sir.
So you have a growth which extending into the larynx, transglottic, and then it can go to the pyriform sinus. I mean, it go to the postcoicate area. Now you tell me where the growth starts from first.
Probably from the pyriform apex.
How do you say? What are the points for that? Go to that slide. Staging. Okay. Now you said you have a malignant growth, hypopharynx, subside pyriform sinus, extending into the postcoicate region and extending into the larynx with the hemilaryngeal fixation. Your stage still the same or different?
With T3 is any tumor more than 4 centimeter with hemilaryngeal fixation, sir. Any T4A comes any cartilage invasion, hyoid one, esophagus invasion.
Pyriform fossa growth goes the postcoicate area. What's the staging?
T3, sir.
T3. So anyway, this is T3 and stage 3. Still it is T3. Still it is stage 3. Okay, it's a locally advanced hypopharyngeal tumor. Okay, how do you say it's a pyriform fossa tumor?
Depending on the history only, sir.
What is stage? No, come on, how it can become a pyriform fossa tumor? This is a fantastic case you have taken. I love discussing this case.
Actually, slough covered growth is seen over the medial part of pyriform fossa.
What is your history? You told history.
Dysphagia, sir. Dysphagia for 4 months, and
Where will you get dysphagia?
Either in the post-cricoid region or in the pyriform fossa apex.
Post-cricoid region only.
Okay,
Pyriform sinus, opposite the pyriform sinus is free. Till it is free, you can swallow.
Okay, sir.
There will be a foreign body sensation. There will be a referrodontalgia. There will be a food sticking in the throat. But you will not get dysphagia. Okay. So why can't this be a pyriform post-cricoid growth coming to the pyriform sinus?
Transglottic extension was there, sir.
So what? So what? How will you discuss this? Tell me the points for pyriform sinus.
The progression of symptoms like ear referrodontalgia was there, and patient had following that the patient had
what are all these symptoms to say? It starts from the pyriform fossa.
It's a referrodontalgia, sir.
On examination.
On exam,
I described history because you told history. Always you talk about on examination finding first. History, all this. Next it comes. Why you say this is a malignant growth hypopharynx?
Because the slough covered growth is seen more on the pyriform fossa, sir. And
I understand the question and answer. Why do you say malignant growth hypopharynx? What are all the points to say it's malignancy?
It's ulcerative lesion with the invasion to paraglottic space can because of
vocal cord fixation, deeper invasion.
Then deeper invasion, then lymph node is involved.
Lymph node involvement. Then
bulge.
A classical irregular slough cover proliferative growth with the everted margin is seen on the pyriform fossa extending to the postcoicate area. So this growth cannot be a benign growth. Why it's not benign? Because one is infiltration, deeper infiltration to the paraglottic space and the focal part fixation. Second one is secondary to the neck. So to say secondaries, you should have told it's a hard node. But they will come and check it up. Preferably, you say firm to hard node, but you are written it as firm. You should say firm to hard. That's a secondary character. Then patient loses weight. Patient goes for progressive dysphagia. Which occurs on an old man, smoker, alcoholic, smoker, and alcoholic. So most probably it's a malignant growth. Why pyriform fossa?
Because bulk of the tumor.
Why not post-operative? What? Because
bulk of the tumor is seen on the
center of the tumor is seen in the pyriform fossa.
pyriform fossa.
A tumor from the post-operative area usually spreads to both pyriform fossa. That's what I told you. It goes to both pyriform fossa. Tumor never spreads in only one direction. It spreads in all directions. Okay. So whenever there is a post-operative growth, there will be an upward spread, there will be a lateral spread, there's a lower spread. That's why we discuss about this spread. Okay. So if it comes laterally, it should have gone to both pyriform fossa. There is more tumor in the apex of the pyriform fossa and the upper part of the pyriform fossa than the post-operative area. Okay, first thing. Second thing is there is an anterior extension. Anterior extension, I told you, the larynx will not get involved in the post-operative tumor. Anterior part of the larynx will not get involved. If at all it is fixed only the trichoarynoid joint. Then it goes to the pyriform sinus. From the pyriform sinus, it goes into the paraglottic space. Okay, but that is rare. So, the center of the tumor is pyriform fossa. It spreads medially, it spreads lower down into this thing, and because of that, there's a minimal pooling of saliva. So, most probably your tumor is pyriform fossa. I agree with you. But you got to be very clear in presenting your. Yeah, so the malignant growth, hypopharynx, left pyriform sinus, extending to the paraglottic space with a heavy laryngeal fixation, extends to the larynx. Then inferiorly it goes to the post-operative area, which causing the pooling of saliva on both sides. So 2-3 things you should have told when you are presenting like this, right? So few things you got to cook up. Cook up is if you would have told patient had 3-4 months duration of food sticking in the left pyriform fossa, and then 3 months left ear pain and dysphagia is of cell in place. But you are a Harichandra who don't lie. That's a problem. You don't cook up. Okay. Second thing is when you describe the tumor, describe in such a way that the examiner accepts your diagnosis. Okay. Okay, fine. Everybody accepts your diagnosis. What are you going to do to the patient?
First, video laryngoscopy, sir. Then after that, upper esophageal speculum or hypopharyngoscopy can be done. For taking biopsy or not? Take biopsy by under hypopharyngoscopy.
Hypopharyngoscopy. Sure. Will you get fitness for the patient? You don't think patient will go for stridor?
Yes, X-ray.
Will you confidently intubate the patient and extubate? Or you want to do it under local anesthesia?
There can be laryngospasm can be there.
So,
and also this tumor is also deep inside the pyriform fossa, so adequate chunk of the tissue for biopsy couldn't be get.
So you want to do it under GA?
Under GA or under relation?
That's barbaric. Doing hypopharyngoscopy under LA is barbaric. Okay, how will you give anesthesia?
Internal.
For hypopharyngoscopy, local, internal. How will you give the internal block?
In the thyro, 2% xylocaine is taken in a syringe, and hyoid, greater horn of hyoid is palpated, and thyroid superior horn is palpated, and in between the midway between the thyroid membrane will be there. And
Agreed. Anything else you do? Any other local anesthesia you give?
internal.
Is this enough? Internal block will you give? Internal block is called what?
Sorry, sir. This is external. Internal is using McGill's forceps anesthetic 4% xylocaine
Where will you give?
in the both pyriform forceps. But
What is there in one? What is there in one pyriform fossa?
tumor is there, so it may bleed and it will obscure the field.
So then what do you
So
do?
better to go for biopsy under to do under GS.
Do you think you can intubate and extubate with one mobile card? Such a big bulge in the area, epigadic hole. You confidently take it out. Don't you think this patient will develop stridor?
But
Is there a possibility this patient develops stridor now?
If post-cricoid region is involved, there is a chance.
No. Now, single fixed hemilarynx will produce stridor or not?
No, sir.
No.
Mild turbulent.
Mild turbulent, moderate turbulent, severe turbulent will become severe stridor. See, growth involving entire length of pyriform fossa extending to the area, extending to the false focal cord, subglottic extension, and right hemilarynx is fixed. Will the tumor develop stridor or not? How many tumors you have seen total laryngectomy done? Last case, when we did a total laryngectomy, they did a low tracheostomy for a stridor patient and landed up in total laryngectomy. Is it not stridor? Hemilaryngeal fixation will produce stridor. When you give an anesthesia, if you don't give properly, you don't take it out at a proper time, you use a big tube, patient can develop stridor. So what are all your options?
To do a high tracheostomy, sir.
You want to do a tracheostomy for the patient. You know, you do a tracheostomy, you can't discharge the patient. You are going for a compromised laryngeal function, then you got to do the surgery. There is no point in going for a organ preservation. Already your organ has lost this function. What do you do? That's why I said it's a beautiful case to discuss. It is you should discuss and tell me. What should you do?
The post-operative.
Sir, we are from the higher center, sir. We have jet ventilation. We can give an awake anesthesia.
But if we have to palpate cricoid joint and the GA with the endotracheal tube will be good, sir. So
first you do is take a biopsy with the video laryngoscopy. Simplest thing. Take the biopsy. And don't treat the patient with that. Send it for biopsy. Then you do a hypopharynxoscopy. Do an hypopharynxoscopy under anesthesia. Use like a microlaryngeal excision. Use a smaller tube. Get a good anesthetist. Intubate. Examine all the area and take out. Okay. So you got to be ready with the tracheostomy and the tracheostomy consent. If you want to do a tracheostomy, do an eye tracheostomy. But you got to be ready. Okay. So with all these things, what are all things you will see when you put a scope inside?
The extent of the tumor, sir.
What extent of the tumor?
If the cricoid is involved, post-cricoid region.
What intubation you will do?
Sir?
What intubation?
ET tube in the.
What?
Smaller size tube.
Nasotracheal or orotracheal?
Orotracheal, sir, because orotracheal, sir. Then only
sure.
we can.
Microbiological examination, you do a orotracheal.
No, sir, but we have, if we have to see the post-cricoid region better, then we
Good.
do.
When you do a laryngeal examination, it's always nasotracheal with a long tube. What do you call as a microlaryngeal tube, MLT? Okay, through a nasal intubation. If you examine or remove the foreign body or take a biopsy from the post-cricoid area, or you want to do a esophagus, always orotracheal. Because if you put a nasotracheal, you got to cross the tube. Always you put the orotracheal. Okay, then how will you take biopsy?
Biopsy to be taken from the margins of the tumor, not from the fluff covered areas.
You take it with the punch forceps.
Punch forceps, multiple biopsy.
See, listen, examination can be so cruel. You will be thinking of omental patch. They will be asking you what forceps you use. You think there'll be something like a Kuva's forceps or a big name forceps, and then they'll tell you it's a punch biopsy forceps. So think base level also. Okay, so you take the biopsy from the punch force. Okay, then
the joint can be cricoid joint can be more palpated. Then extent of the tumor to the esophagus.
Push the area epigastric push the false vocal cord to look for tumor. Then cricoid joint mobility. Balloon up the opposite side piriform fossa to look for a tumor. It can still be a post-cricoid tumor going to the opposite side to piriform fossa. Check it out. Then go into the piriform sinus. See that lower extent of the tumor. All these things got to be done. Okay, what other investigations you do?
Radiology.
Why you want to take biopsy?
To prove the to prove the growth as malignant, and also for the histological differentiation of the tumor, and also for deciding the prognosis of the disease, and also for checking about the infiltrative pattern of the tumor. So if
first thing is benign or malignant. Second thing is histology, whether it's a squamous disease or non-squamous disease. Okay, because the treatment depends upon that. And a sarcoma will not be amenable for radiotherapy. You got to think of surgery. And adenocarcinoma, adrenal cystic carcinoma will not neuroectodermal tumor will not be amenable for radiotherapy. Then you got to look for differentiation. Why differentiation? How do you?
The local recurrence and the prognosis depends on the differentiation.
Differentiation. How do you classify differentiation?
Classification, sir. If grade one is 25% undifferentiated tumor, more than 75% differentiated tumor. Then grade 2, 25 to 50% undifferentiated tumor, and grade 3 is more 50% to 75% undifferentiated, and grade 4 is more than 75% undifferentiated tumor.
So what is the other way of taking biopsy? All these things. Why I asked about all these things is because there is a better way of doing this. Go to foreign countries, you can't do a video laryngoscopy. Why? You can't pull the tongue.
Operating.
You can't pull the tongue. If you pull the tongue, the patient will shout.
Flexible
flexible laryngoscopy. Flexible laryngoscopy. Go inside, examine all the area under local anesthesia, and you can take the biopsy. Okay, so that also you should keep in your mind. Flexible scope is a alternate for your GA. Only thing you can't do is you can't
palpate.
Really palpate. You can still palpate with your. You can put that biopsy channel probe, and you can just touch and see, but you can't probe. Okay. NBI we have discussed even on that last time. So NBI is not the foolproof method. What's the point of doing NBI? You want to see any other area of involvement, like different areas, second primary. See, for NBA, it's okay. But generally, NBA will tell you increased vascularity, most probably malignant. But still, with that, you can't do a excessive surgery. For example, if the tongue base is involved, you can't remove the tongue base with that one. You got to take a biopsy and prove that there's a second primary. What are all the investigations you do for this case?
Radiological CT of neck can be done, sir. And
Okay.
also MRI can be done, which will supplement the CT findings. Then X-ray neck and X-ray chest, X-ray chest for the looking for the primary metastasis, looking for aspiration, for anesthesia fitness, then looking for TB cavity, and for
This we have discussed that day. Okay. So X-ray test is for pilot study,
pilot
primary, extension, primary, second primary, then look for the secondaries and look for mediastinal extension, look for aspiration pneumonitis. Then you look for cardiac evaluation, pulmonary function test. Then you look for any immunocompromised patient, any cavitatory lesions, any fungal ball. All these things can be diagnosed with your X-ray chest. Another important thing is, even he is 100% fit, you take an X-ray chest and keep it with you. You can compare it with the patients in the due course of its treatment. Okay. Then what else you do?
USC neck and USC neck can be done for evaluating the lymph node status. Then FNAC from the lymph node, I will do.
FNAC from the lymph node. Okay, right. Then anything else?
Then barium swallow, OGD-scopy can be done, sir.
OGD-scopy for what?
For for assessing the extent of the tumor to esophagus, because
nobody sees Hypopharynx in the OGD-scopy. You know how many times they say Hypopharynx cannot be seen with the OGD-scopy. So lower extent of the tumor, OGD-scopy, no, you got to do a you got to do a esophagoscopy, not that flexible esophagoscopy. Okay, only esophagoscopy, not that OGD-scopy, that flexible thing. That will not see, but that flexible thing got to be done to rule out second primary.
Second primary in the esophagus.
Okay, X-ray chest and CT chest and the OGD-scopy will differentiate secondaries, and then you got to assess the stomach, and also you got to do a barium needle series, and you got to do a colonoscopy. For what?
If reconstruction is planned,
if you are planning for surgery, if your reconstruction option suddenly it goes to that area, you got to be see whether it can be done or not. You got to be prepared. Any other test you do? For all these things, PET got to be done. PET scan got to be done. Why?
Because it can assess any primary lesion, second primary lesions anywhere in the, and also metastasis.
Distant mets. Okay, distant mets, second primary, operability of the tumor. Okay, this is about the investigation. So with all these investigation, what is the thing you can do for the patient?
For this patient, multimodality treatment, curative treatment I will give.
You want to give curative? Sure.
Yes,
there is nothing to say this patient requires palliation. It's fine. They do a curative treatment. What do you give?
I will go for total laryngectomy with partial laryngectomy with the reconstruction. As the
what will you reconstruct with?
flap.
What do you reconstruct with? What will be your lower extent of dissection?
Depending on the operability, sir. If post-cricoid region is involved, I will do OMS procedure, sir. If
so you want to do an OMS procedure. What is the survival rate of OMS procedure? 5 year survival rate? They don't talk about 5 years survival. They talk only 2 years survival.
2 year or 3 year. Less than 20%.
And then why you want to operate such a big surgery for the patient? What are all the indications for surgery in this group of patients?
For this,
Got to be ill and healthy, without any big morbid conditions. Okay, hemilaryngeal fixation. Right, then.
mobile neck node is an indication for surgery.
Okay, right.
And,
vertical length of the tumor is more than 4 centimeter. Bulk of the tumor. Then
radio recurrent and radio residual growth.
This is not radio recurrent, radio resident tumor. If it was a radio recurrent, radio resident tumor, you will straight away go for surgery. But this is not radio recurrent tumor. Then what will you do? I will do a tracheostomy and send the patient for chemotherapy. Because I have an alternate chance of doing a salvage.
Okay.
That would have been a better option. That's what we do in MMC, right? You see, this exam is done for everybody in their colleges, what they do for that case. Okay, it's not what they do it in Europe or what they do it in US. It's what you do in your college. If you do surgery, tell surgery. If you pipe mucosa growth with laryngeal fixation, what do? Do a tracheostomy, send the patient, you present the patient in tumor mode, they will tell you go for a chemotherapy. Happily, please send the patient. If you want to operate, close your arms and itching, wait. Brand them as a radio resident, then you have an option. Straight away, I don't advise surgery for the patient. It's given in great books, but we don't do it in our part of the world, particularly in Madras Medical College. Right. So this is the ideal patient to go for a chemotherapy. But because the hemilarynx is fixed, you got to be careful. If you keep the patient in a hospital and give a 2-week chemotherapy, you will see whether the patient will go for stridor or not. If the patient goes for stridor, put the patient on CPAP, load him with the steroids and the bronchodilators, get your theater ready and do a tracheostomy. 24 hours you have cover, right? So that's not a problem. But if the patient doesn't develop stridor, tumor shrinks in size, and there is a restricted mobility alone, you can save the organ. Okay. So what is the drug you give? How will you give chemotherapy?
Cisplatin and 5-fluorouracil.
Okay. How many cycles?
The cisplatin is given on day 1, day 7, and day 22 and day 43, sir.
Okay.
At the dose of 100 milligram per meter square on these 3 doses, sir. Or another alternate regime is 30 to 40 milligram per meter square on weekly basis for 6 weeks. Also can be given.
Okay.
And
Then
5-fluorouracil, it can give 1000 milligram per meter
so
square.
this is called PF regime.
IV infusion.
What is TPF regime?
Taxane and taxines are also in.
Paclitaxel. That's what we use here. Okay. Then now will you give a how much radiotherapy you will give?
60 to 70 grays, 30 or 2 gray per fraction for 30 to 35 cycles, sir.
How many grays?
60 to 70 grays, sir.
60 to 70 grays.
How
many grays a day?
2 grays per day for
1.8 to 2 grays.
5 days. For the first 5 days and 2 weeks rest. After that, given for 6 to 7 weeks, sir.
Any other way of giving radiotherapy where you can increase the dose?
It's accelerated and hyperfractionation can give.
Hyperfractionation, accelerated, then you get an accelerated hyperfractionation. All these things are all different. With what you will give radiotherapy? What is IMRT?
Intensity modulated radiotherapy, sir. So that adjacent structures are receiving a low dose of radiation, so that toxicity can be reduced.
What are the precautions you take for this male when you give radiotherapy?
No, the surface should be wet and not to shave, and not to use any iodinated
Before that, what do you
dental
dental
prophylaxis.
removal? If not, what will happen?
Osteoradionecrosis of mandible canal.
Osteoradionecrosis of mandible. So, what do you got to check for focal sepsis? There's any focal sepsis, you got to remove the focal sepsis. You give a dental care. Dental caries. Okay. Then how will you? It's already 9:20. What do you want to discuss more? Radiotherapy or surgery? Okay. Radiotherapy or surgery?
Surgery.
You want to discuss surgery more. You don't want to see what are the complication. How will you manage oral hygiene? The post-operative period, patient will have a loss of saliva, dry mouth. How will you clean the tooth?
Radiotherapy.
These are all the complications. So what are all immunomodulators? So all these things you got to be read. Okay. So if the patient gets a radiation failure, then what do you do?
Then for advanced disease, immunomodulators are there. Cetuximab is used for.
No, this is radiation failure. Then what will you do?
Salvage treatment. Sir.
What salvage you do?
For this case, total laryngectomy to partial pharyngectomy can be done.
Total laryngectomy with partial pharyngectomy. Apex of the peripompous is involved. This is too close to the cricoid cartilage and too close to the midline.
If a cricoid involvement is there, then total laryngectomy, the total pharyngectomy has to be done.
Okay, because you take it only a partial. If it's on the lateral wall of the pyriform sinus more than the medial wall, then what will you do? If it is only on lateral wall, radio-recurrent growth, what will you do?
Then near total can be done, sir. If
no vocal cord involvement. There is a tumor, radio-recurrent tumor on the lateral wall of the pyriform sinus. What will you do?
If
lateral wall of the membranous part of the pyriform sinus, what will you do?
If the tumor is so small, it comes to the T1 or T2 stages. I can do either
T1 or T2. What will you do?
T1 or T2, either open or internal approaches can be done, sir.
Oh, you have laser in your hospital? TLM? What do you do? What is the ideal thing to come next?
Lateral pharyngectomy can be done, sir.
Lateral pharyngectomy and partial pharyngectomy.
Partial pharyngectomy.
So how will you reconstruct?
If remnant mucosa is more than 2.5 centimeter for the stretch, then I can do primary closure, sir. If it is less
always
than,
primary closure. Then, if not,
if less than that, then I will do patch techniques, sir. So that PMMC flap or any radiforum flap is augmented
which
with
one?
that.
Which one? Microvascular.
Micro, sir.
Radial flap. Pedicled flap or microvascular? Pedicled means what do you do?
Pedicled means PMMC, sir.
PMMC. Anything else?
Deltopectoral can be.
Deltopectoral for a lining. For cover deltopectoral fine. For lining, how will you take the skin inside? Difficult.
Tube reconstruction can be done, sir. For
which one?
Tube skin-lined tube reconstruction with.
That is for the total pharyngectomy, not for this. Pec major, you have a sternocleidomastoid, you have a lateral cervical flap. Okay, so that's a very small defect. You can primarily leave suture. If you can't do it, if this case there is an apex and the pyriform fossa is free, what will you do?
Partial total laryngectomy to partial pharyngectomy.
So how will you reconstruct?
Same, sir. If relaxed segment is less than 2.5 centimeter, I will do with patch technique. And if it is more than 2.5 for the stretch segment, primary closure can be done, sir.
What patch technique?
The augment the mucosa with PMMs.
That is pedicle. What is better one? How will you give skin? Wookie's flap are all pedicle. Wookie's flap is outdated. It's only a skin tube. Okay, that has got a lot of problems. Okay, what you do is you can give you have a skin lined flaps or mucous lined flap. Skin lined flap can be anterolateral thigh or a radial forearm flap. Radial forearm flap. We want a mucous line, you take a free jejunal flap or a stomach with omental patch. Stomach with omental patch. Okay, for that you got to do a microvascular anastomosis. You don't have a facilities of a microvascular anastomosis. Then you got to do a neck major or sternocleidomastoid, lateral cervical flap. Okay, for any one of these flaps. If you remove it completely, then what do you do?
Then jejunal flap can be done.
Jejunal tube flap.
Tube flap and skin lined tube reconstruction with the radial anterolateral thigh flap and radial forearm flap.
Radial forearm flap. Okay, so if your apex of the pyriform fossa extends into the postcricoid area, then what will you do? What will you do for the neck? What will you do for the neck?
MRND will be done. So if neck is
you don't sterilize the neck with the radiotherapy. It's a radiation failed case. So N0 neck you need not operate because you already sterilized with your surgery. You are doing only salvage. Okay. If you are primary surgery, whatever you do, you got to irradiate the neck. Or if you want to give a chemo-RT, the patient is doing exceptionally well, wait for 6 weeks and then you got to do a MRND on both sides. Or MRND on the left side. Okay. Then if the tumor is not reduced, this still you got to do an MRND. If you give a radiotherapy and the primary is controlled well, but the node is not responding, then you got to do an MRND. Okay. Then if it's the apex of the pyriform fossa is involved, what do you do?
Total laryngectomy, the total laryngectomy.
And the pyriform fossa, post-cricoid is involved.
If post-cricoid is involved, I know total laryngectomy with the total laryngectomy with the esophagectomy with gastric pull-up.
What is that called?
Ong's procedure.
Ong's procedure. So Ong's procedure, how do you do?
After putting the Glucksorensen incision, sublatissimal flap is elevated and the omohyoid muscle is cut and the bilateral carotid
bilateral no notes.
Neck node dissected. Then after that, thyroid superior and inferior thyroid pedicles are ligated. Strap muscles divided and retracted. After that, thyroid pedicle is ligated, and thyroid gland is mobilized, and thyroid cartilage is skeletonized on the lateral side, and after that, hyoid is skeletonized and valvular is ended as per the total as usual the total laryngectomy steps, and the posterior border of the posterior plane will be between prevertebral fascia and the buccopharyngeal fascia. So I will separate that, and after that the trachea in the total laryngectomy specimen is taken in toto, and midline laparotomy incision is done, and using finger dissection, gastrostomy is tube-like gastrostomy reconstruction is pulled towards the neck of the patient, and it's reconstructed to the upper part of the neck.
No. I didn't hear. I didn't listen to you. 1 minute. Tell me again.
After
You have skeletonized the larynx. Enter the enter the larynx through the vallecula. Then what do you do?
Then the posterior margin of the posterior plane is between the prevertebral fascia and the
Make
pharyngeal.
a circular opening of the pharynx at the level of the base of tongue. Okay, then you separate the pharynx from the
Prevertebral fascia.
prevertebral fascia. Before that, how will you check up whether the prevertebral fascia is fixed or not?
Lateral mobility will be restricted in if the
Before opening up the case, you got to look for the tumor fixing on the prevertebral face. If it is fixed, you can't operate the patient. Okay, you can do a MRI to confirm pre-operatively, or you take a barium swallow and look for the movement of the larynx. Okay, so once you have done that, then you can do this. Okay, then tell me.
The midline laparotomy incision is made by the surgical gastroenterologist.
That's all.
The total larynx and pharynx is taken out and trachea is anchored.
Taken out?
No, not taken out, sir. The esophagus is mobilized and the whole specimen is taken out in total.
You do a tracheal resection. I mean, you do a tracheostoma, take out the tube, insert into the tracheostome and preserve the trachea. Then you put a clamp and cut the level of the upper end of esophagus and keep the clamp with you so that you can do a finger dissection from above. From below, midline incision, they will mobilize the stomach and do a dissection of the thoracic esophagus from below. Both the people finger will get they touch each other. Then the dissection is completed. Then they pull the stomach up along with the esophagus. And once that stomach comes to the neck upper end, it is cut, and the preferable place of anastomosis is selected. They close the upper end. Preferable site of anastomosis is selected, and that is circumferentially anastomosed to the base of pharyngostome. Okay, they'll anastomosis. That is called the total laryngopharyngoesophagectomy with gastric pull-up. Why you don't do anything else? Can we do a jejunal free flap?
Jejunum, the microvascular flap, more chances of failure will be there, sir.
Why?
Because the blood supply is compromised.
So it is difficult to take such a long segment and put it inside the thorax and give an anastomosis from above and below. So easiest thing is gastric pull-up. Okay. Then what is the advantage of gastric pull-up from the colon?
There only one anastomotic site will be there, and so the leakage and comorbidity will be less. And also, if a colon is placed, there will be the voice speech quality will be less inferior compared to the gastric.
That is for microvascular flap. Stomach momentum patch, not with gastric pull-up. I have done a TEP and saw the patient. The patient was talking. You have presented in the all-day conference as a talking stomach. The voice quality will be very less. Okay, if you only when you take a microvascular flap, gastric pull-up, quality is still poor only. Then
there are more comorbidities with the colon flaps.
What happened to you? You were very, very bright when you have started. You have become like very tired. Okay, if it's a pyriform for a growth, you do a MRND. If it's a post-tracheal growth, what will you do? You do neck dissection?
Yes, sir.
Usually we don't do. because it's already a morbid surgery. We don't do a bilateral neck dissection. If you injure the jugular on both sides, it's trouble. So we usually don't do. Okay, if there is a node is present, suspected area, then we will do. Okay, so how will you follow up the patient?
For the first year, 2 to 3
Patient is not able to breathe. After surgery, patient not able to breathe freely. What do you do?
any tube block should be suspected.
Total laryngectomy you have done, end tracheostomy, tube blocker.
Any aspiration can be there, sir. Aspiration.
What aspirate? From where?
Pneumothorax.
First day, you don't even start food. Will you do peg for this patient?
Sir, second.
Will you for feeding? Will you do peg for this patient?
Percutaneous. Peg.
That day we told instead of Riles tube, we'll do peg. Instead of Riles tube, will you do peg for this patient?
Yes.
You pull up the stomach, you do peg. Where do you do the peg then? Where is the stomach in the abdomen? You already pulled it up. Feeding jejunostomy. Feeding jejunostomy. At the same time, you can do a feeding jejunostomy. Okay. Then when you are pulling thorax, inside the thorax, patient can develop pneumothorax. Always take an X-ray. Look as per auscultate. If there is a pneumothorax, what will you do?
ICD has to
be. Those days, some 15 years back, whenever you do a gastric pull-up, we'll do a bilateral ICD incision as a precautionary we measure. Now we don't do, but those days we used to do. Okay, then if the patient develops bradycardia, what is the commonest cause? Immediate post-op. You bring the patient to the post-op. Patient has got bradycardia.
Hemorrhage.
Hemorrhage. You will develop bradycardia.
Sorry, carotid compression.
Carotid compression. Any patient, even mastectomy patient. Otherwise, patient is fine. Patient is got bradycardia. How will you reverse the patient? What do you give? Reversal you give, no?
Yeah.
Neostigmine with atropine. Why atropine? Neostigmine, when you give reversal, it will produce bradycardia. So to compensate that, you give atropine. If your atropine dose is not sufficient, patient will go for sinus bradycardia. So what do? Give atropine. Take a ECG, see whether it's a sinus rhythm, it's a sinus bradycardia. Give a small dose of IV atropine, slow IV atropine. Okay. Then when will you start orals?
After 7 to 10 days after normal.
Day. After 10th day. Okay. So how will you follow up the patient?
For the first 1 year, 2 to 3 months follow. And
when the patient comes, what do you do?
So clinically examine for any lesion, and then hypothyroidism can be checked, sir. And then any metastasis, second primaries or secondaries developing can be checked. And then speech, if available speech.
Within 2 months, you do speech, is it? For a stomach, gastric pull-up, or a microvascular preflap, you wait for 6 months. When everything is fine without any complications, you do. You don't want to produce a fistula. Okay. Then what do? You do an abdominal ultrasound. You take an X-ray chest, or you do a bone study. Okay, look for secondaries. Every 3 months you got to check for this, doing a non-invasive procedures. After 1 year, what do you do?
After 1 year, just X-ray for the follow-up.
How many days follow-up is?
6 monthly. In the second year, 4 to 6 months follow-up is done, sir.
Okay.
After,
What do you think the survival rate?
2 to 3 year survival rate is for first stage 1 it is 40, stage 2 it's 25, and stage 3 or 4 it's 15.
That is for the tumor without node. The tumor with node.
The prognosis survival becomes 1/3.
Okay. What is laryngectomy club?
For the rehabilitation of laryngectomy patients. For
every unit, when they do a lot of laryngectomies, more than 7, 8, 9, 10 patients are there. Every year you should bring everyone together on one particular day to see how are they doing. So you do a small examination for everyone, give small gifts for everyone, give some chocolates, give some sweets, and you can use that time to show the prognosis to the patient who are waiting for laryngectomy. So for that you should have a club. It's called laryngectomy club that should meet every year. Okay, and you take photographs and wish everyone, boost their confidence. If you bring patients who are living for 10 years, the patient who got operated last year would have been more confident. Okay. Right. Anything else you want to ask, discuss? So many things I didn't see. Harsha?
Sir.
Yeah, with this, we are coming to the end of the discussion. It's very interesting for me to discuss this case because it's got a various aspects, and I congratulate Lakshmi for presenting such wonderfully, and it needs guts to. If you go to an exam and you get this case, that's different. But you bring the case for a discussion. We have not discussed this with previously. Probably we would have discussed. It would have been easier for her to adjust the case. But anyway, she did a wonderful job.
Yes, sir. Sir, actually, I'm driving, sir. Can you give the closing remarks, sir?
Yeah. Okay. So with this. Thank you very much, Harsha. Thank you very much, Janagram. But for you, this program is not possible because he is held up in his emergency. I thank everyone for attending this class, and we are sorry that we couldn't do it on the previous day. And tomorrow we'll have a grand rounds for nasal cavity masses. So with that, I thank everyone. Thank you for your patient listening. Thank you.
Thank you, sir. Thank you. We'll see you again tomorrow.
Sure. We'll see you again tomorrow.